Thank you very much for this opportunity to speak for the EOS network, or with the EOS network, and I'm really looking forward to hearing your comments and questions at the end. This is going to be a very different talk. I am primarily a clinician, and research and audit are something that we do in Glasgow very much. But the mainstay of what I do is I manage around 100 patients with eosinophilic esophagitis across the west of Scotland. So I'm going to talk to you about the management strategies we use and the things that we've been trying to develop with the British Society of Paediatric Gastroenterology, Hepatology and Nutrition, together with the EOS network, for developing protocols that will be available around the country for children and teenagers. Oh, how do I move this on? Haha.
Down the bottom left. It should just appear. We've got a little.
Oh,
there we go.
Aha! This is all new for me, so I apologise for that. So, what is the aim of management in eosinophilic esophagitis? And I would say that, as in most diseases, and particularly in eosinophilic esophagitis, there are three strands of management. And first of all, it's really important that as patients or people who have these eosinophilic esophagitis, we get your symptoms under control, because the symptoms can be quite debilitating, they can be very frustrating, and they can affect how you're managing day to day. It's also important for any disease process that we try and make things as normal as possible and decrease any effects of the disease, and clear any inflammation and get things back to as normal as possible. And overarching all of this is considerations for quality of life, so that you know, you can be well on medications or dietary restrictions, but are they affecting how you manage day to day? Are you missing out on things with friends, etc.? And so quality of life is extremely important to bear in mind, and that may help determine what kind of treatments you and your child prefer. This is a very nice slide from America, from Chapel Hill, and this shows that on the left there is where the disease is non-responsive to some response, to on the right hand nice green part of the diagram where there's complete normalization, where you have a completely normal looking esophagus with less than one eosinophil that you get on your multiple biopsies, that symptoms are more than 90% settled, and when you do scoring with looking at the esophagus, it comes back as normal. And this is the ideal. And this group have gone on to describe this year 3 different types of eosinophilic esophagitis based on response, including one group who respond very early, are well more than 75% of the time, have normal biopsies more than 75% of the time, and often need milder treatment, through to a group which is well and normal endoscopies about 25% of the time, through to those who may never or very rarely respond to the treatments that we have to offer. And these are the really frustrating group of patients for us managing them, and very hard for families to deal with when their child has not completely responded to therapies that are offered. So why would we want to treat it? Eosinophilic esophagitis, in my experience, can give very distressing symptoms. Food bolus obstruction and food sticking can be extremely distressing. In younger children particularly, I have experienced children who've had poor appetite. Sometimes it's affected their growth. And we've had a small number of children who have been so frightened by food bolus obstruction or by choking that they have completely refused to eat any solid food. This tends to be younger children, usually early primary school, and can take quite a lot of coaxing back into normal eating behaviours. And of course, all of this with longer meal times, higher levels of drinking water, leaving the table because things are sore, can lead to stress, And obviously, food impaction, if gone untreated, can require emergency endoscopy to remove the offending food. And with time, as Dr. Oliver's expressed it and let us know, that strictures and narrowings can develop, which require therapy in themselves. So I think it's really important to say that it's not just me that sees patients and children and manages them. I couldn't do this job without a dietitian. In Glasgow, we have a joint clinic for children with significant and severe type 1 allergies, the ones that need an EpiPen. And we try and see them together with our consultant allergist in a clinic. We don't have enough of these clinics, and we run about 3 or 4 a year. But this is really useful when we can try and match together especially dietary therapies, because children who are multiply allergic to, for example, peanuts, seafood, and eggs, and then you're saying, well, why don't we take out milk and wheat as well? And it can be extremely frustrating. So it's trying to limit the number of things that you have to remove from the diet, and that's very helpful to do together, as well as to uncover more symptoms in children with eosinophilic esophagitis who may have more type 1 allergies that they've not realized. Occasionally, we involve a surgeon. We do try to keep them away from our patients where possible, but it's often them that you will meet if you end up in accident emergency, when that food bolus just will not pass. We have used psychology. We don't have psychology in our clinics, but we have had extremely helpful support from our local psychologists, particularly where children have not been able to tolerate diet for fear of choking. And it has sometimes taken several months to get these children back onto full diets, usually with some medical therapy. But with psychologists coming to the clinic as well, this has provided the child and the family with a lot of reassurance and techniques to try and involve the school and move things on. It's not common, but it's really important where that happens. And you yourselves as family, as patients, as the person who's affected by the disease, your school, your friends, you are also involved, because you're involved in supporting dietary change, you're supported in taking medications, in determining which is the best therapies, what works, and in feeding back to us as gastroenterologists and dietitians as to what is working and what could go better. So tonight I'm going to focus on 3 management options, that the mainstays of our current treatment. I'm going to talk about proton pump inhibitors, and most of you will know this as either omeprazole, lansoprazole, esomeprazole. You may have tried all 3. I'm going to talk about steroid therapy, and I'm going to talk about dietary treatments. What I'm not going to talk about is the newer treatments, which are still in trial process, such as dupilumab. And I think that is a whole talk in itself. I think what I really want to concentrate on is the mainstays of treatment that we're using day to day. So what are proton pump inhibitors? I imagine a lot of you listening will have had quite a lot of experience with these, because these are the first line treatment and often used doubled up with steroids and diet to try and get extra effect. So these are inhibitors or blockers of the proton pumps, or the pumps in the stomach from the cells that produce acid. So they stop the cells secreting acid. They also therefore decrease the volume of secretions in the stomach, and they work to allow less acid reflux up into the esophagus, which we know overlaps with eosinophilic esophagitis. They also act by mechanisms that we don't fully understand to decrease inflammation in the esophagus, and they may well have an antioxidant effect as well. Dosing is fairly standard. It still quite often causes quite a few GPs to recoil in horror, because the standard adult dose for omeprazole is 20 milligrams once a day. So if you go to your GP as an adult and you have a little bit of heartburn and you can't respond to anything over the counter, they will prescribe you what to them is a good dose of omeprazole. However, we do know that this condition responds very well to significantly higher doses than this. We have agreed limits on how much omeprazole we would prescribe, which would be in an adult 40 milligrams twice a day, and in children up to that level 1 milligram per kilogram of their body weight twice a day. The maintenance dose is usually weaned down to around half of this. So I quite often get calls from the GP to clarify, or the local pharmacist, exactly what we're giving. These are doses that we have been using now for a number of years. They are fairly standard for this condition. How effective then is omeprazole and drugs like it? Well, we know from trials that symptoms will improve in 60% of people, adults and children, who take omeprazole. And that if we then do an endoscopy, inflammation after 12 weeks will have improved in about half of all patients. I quite often use omeprazole even for reflux twice a day, and especially in younger children, because it tends to break, some people it does break down in a much shorter way than 24 hours, which it's meant to work over. And it appears to be a lot more effective for eosinophilic esophagitis if the dose is split into 2, which is a bit boring for taking medications, but it does have a significant, seems to have a clinical significant impact. Stopping omeprazole, as you're probably all aware, you have to wean off it slowly, because when you use omeprazole, it blocks the acid production. So the body goes, where's all the acid? Let's produce some more cells. So it produces a few more cells. And so when you stop omeprazole, your body will have more acid producing cells, and you will get a higher surge of acid. So we usually recommend, if people are going to stop omeprazole, they wean off over a period of weeks. Unfortunately, when you stop it, most patients will then relapse within a few months. So how effective is omeprazole as a maintenance therapy? Should we continue omeprazole? Well, there is evidence, there's a quite considerable evidence now, that after you've achieved remission, you've done an endoscopy, your symptoms have improved, the endoscopy findings are better, the histology, the eosinophils under the microscope, all of that has improved. We can then reduce the dose gradually. And 4 out of 5 of children from studies that have been done will still be in remission at a year. And there's evidence that this effect can last at least 2 years. Oops. So we are using this as a long-term therapy. Obviously, there's been a lot in the news, and I'm sure many of you will have read horror stories about side effects of proton pump inhibitors. All of us in gastroenterology now have patients who have been on proton pump inhibitors for probably different reasons to this, but they've been on them for 20 odd years. There are big studies of adults who have a different condition called Zollinger-Ellison, where they overproduce acid and they have to remain on this for life, or they get significant ulcers. And the side effects profile appears to be better than quite a lot of the studies that have been done, often in very elderly people. So the common side effects are diarrhea, abdominal pain, headache, urticaria, and yes, we all have to stop patients and people who have eosinophilic esophagitis, they have to change the medication if these side effects develop. And I have seen all of these side effects. Less common side effects are usually after 5 years. So we know that using omeprazole and such products for 5 years from these long-term patients is extremely safe. And there's a very recent long-term study of over 3,000 patients which have shown limited side effects even after 3 years. The side effects are more likely in elderly patients who are usually on multiple drugs, have multiple other disorders. However, it's really important to remember that there are some significant long-term side effects. So We do see a slight increase in the number of chest infections that people can get in the community. I do have children that I see who have severe underlying lung diseases who are on omeprazole, for example, cystic fibrosis. They do not come in with repeated chest infections needing antibiotics. It's a very small increase. You do see a slight increase in infectious gastroenteritis. And again, this is on a very large scale of large number of people, but it does happen a little bit more than you'd expect in a normal population. The thing that has been more significant probably is iron absorption, and there is evidence that over time iron absorption is affected. What we're not sure about is in young healthy children and young adults how much your calcium metabolism will be affected. It appears to be affected certainly in elderly population, so it's important that if you're going to remain on these medications for long periods of time, that probably once you've been on them for 3 to 5 years, we should definitely be checking calcium, B12, magnesium. I've only ever seen one case of low magnesium, and that was in a child who had other reasons for low magnesium as well. So it's important to bear these in mind, and it's important that your doctor and your dietitian are aware of them so that we can make sure that if you're getting tired, if you're getting other symptoms, we can check iron, etc. Steroids are the other main drug that we use in eosinophilic esophagitis, and in the past eosinophilic esophagitis was called the asthma of the esophagus, and in fact there are very similar parallels. It's allergy in a part of the body that is exposed to things as they immediately come into the body. Steroids seem to work in a similar way by locally attaching to the lining either of the airways or the esophagus, and they tend to work as you give them over a period of time. Corticosteroids are been around for many years. We have been using them for at least 50-60 years for many other inflammatory conditions. You may have been on them for other reasons. They are based on the naturally occurring corticosteroids in the body, and they're important in normal life for the normal stress response and regulation of inflammation. So it's important in normal life, but we find that they're really helpful in dampening down inflammation. So how swallowed steroids work is that they come into direct contact with your inflamed esophageal tissue and block substances that trigger allergic and inflammatory reactions in the esophagus, and they're very effective in many patients with eosinophilic esophagitis. There are several different preparations. Originally, we were using swallowed inhaled steroids such as fluticasone. These can be a little bit tricky to take, especially for young children, to master the technique, and can be unevenly absorbed because you're not always swallowing the whole amount. So we tend to use viscous budesonide, although recent studies suggest that most steroid preparations are fairly equally absorbed. And these are nebulized budesonide is contained in a small glass vial. You break the vial and you mix it with a suitable carrier. Or more recently, licensed in adults but not yet in children, is an effervescent budesonide tablet that you put on your tongue. And I have it from reliable authority from one of my colleagues that they taste vile. So, but they are very effective. So there's some evidence a couple of years ago suggests that swallowed fluticasone was less effective in children, but a more recent randomized controlled trial of adults who certainly should have good techniques suggests that either preparation is good. The results for the dispersible tablets is probably more like 80%, so it may be better, and I'm hoping that we can begin to use these, especially in older children with eosinophilic esophagitis. So there are different ways that you can mix your nebulized solutions. You can use Blend solution, which if you come from Sheffield, you may be on this. If you're in the south of England, they quite often use Splenda, which is an artificial sweetener. In Scotland, we use 10 to 15 mils of simple Linctus or simple syrup BP. All of these will be effective at lining the esophagus and coating it so that the steroids can work locally. How do we take it? Well, you take it after breakfast and then last thing at night. So the main thing is that you take it and be prepared not to eat or drink for at least another 30 to 60 minutes. I usually say 60 because that can kind of sometimes eke its way back towards 30 if you're not thinking about it. It's really important then that you don't swallow when you clean your teeth, but you do clean your teeth, especially if you're taking a sugar-containing preparation. I think the Americans sometimes use apple puree. And don't swallow the toothpaste or the water when you're cleaning your teeth, but spit it out and don't have anything else for at least an hour. And then in the evening, nothing to eat or drink until breakfast time. And that can be fairly easy to forget over time. We should be reminding you every year or so, are you doing these things? How long do we take steroids for? So initially, it was thought that a 12-week course was adequate. There is more and more evidence, especially in the last 1 to 2 years, that actually we should continue steroids. The new BSPGHAN guidelines, which is the European Society for Paediatric Gastroenterology, will be coming out soon, and they are going to recommend that we continue on with swallowed steroids at a lower dose. If you stop steroids, then nearly all patients will relapse. And I do have quite a few patients who have been on maintenance steroids for at least a couple of years. Long-term maintenance is likely to be very safe, and it's certainly associated with a decrease in food bolus obstruction. And usually you can manage with a lower dose than your initial treatment dose. Side effects, everybody's worried about side effects of steroids. When you're on very high dose steroids, then if you're inexperienced with those, you'll know that they can make your skin thin, they can affect your blood pressure, they can affect your blood sugar metabolism. What we're using is a much smaller dose. There are some cases where you can suppress the body's production of steroids. So when we're using steroids in children in Scotland, if you're on a very high dose of budesonide for your body weight, then we would think about if you're going to wean it down and stop it, then we would think about before you stop it, checking to see whether your steroids in your body are still able to produce themselves, or you need to wean off the steroids a little bit slower, and that's called a synactin test. And we do that on a few children every year in the Children's Hospital. The other important thing is that if you're on a dose which is a reasonably high dose, and you should let any doctor know if your child comes to A&E, if they've broken their leg, if they have a significant accident, if they've got a vomiting illness and can't take the steroids, because it may be that if the child is that unwell, that you may need an extra little boost of steroids to get you through. And it's worth always highlighting if you come to hospital that you're on steroids. I have seen very little side effects in terms of thrush or candida infection. The incidence is around about 2 in 100 in adults, probably less in children. And to be honest, I think of the patients, I probably should have seen about 2 or 3. I haven't seen any as yet in the last 2 or 3 years. I have had one in the past. So it's not as much of a problem as people think. One of the biggest one of the biggest issues with taking steroids is a concern by family members and the person with the eosinophilic esophagitis themselves that we're actually masking the disease and we're not doing anything about the disease. And I do understand that perspective, and I think to a degree that's right. But that's the same as for other diseases where we use steroids, like asthma, joint issues, like a joint disease, where actually what we're trying to do is calm down the inflammation, because we don't have any other way of keeping things under control. So it's not masking, it is treating the inflammation, but what we don't have is a cure for the disease as such. And I think that makes it very frustrating for people who have long-term medical problems. So dietary therapy sounds great. It's great in theory, and when it goes well and you respond to one food you take out of your diet, it's amazing. When you've already got lots of food out of your diet and someone asks you to take out another 6, that can be extremely difficult to do. And I particularly teenagers who go out for school lunch in Scotland. I don't know quite what it's like in England, but in Scotland, kids take money to school and off they go at lunchtime, and they go out and they go to Subway and they go to McDonald's, and they're not heavily known for their gluten-free or milk-free products. And this can be very, very difficult. So this is the main way that we manage eosinophilic esophagitis without drugs. There are several things that we can use. The 3 are elemental diets, targeted elimination diets, and what we call empiric, which is best guess elimination diets. And we're quite good at guessing which the best foods are. And in fact, this is probably the best way to treat eosinophilic esophagitis with diet, unless you are significantly unwell. Elemental diets sound amazing. 90% of patients respond to them. Decreased esophageal inflammation, you're feeling better, fabulous. But they come with a lot of problems. They are very difficult to take. You can't eat food at the same time. So I limit them to very severe disease where there's been significant narrowing in the esophagus. I can't get an endoscope past, that the person has difficulty swallowing and is not responding to other treatments. And we use them for around 6 to 12 weeks. They can be used as a short course of therapy every year if other therapies fail. And this is one thing that can be considered, to use them as a short, sharp shock to decrease the inflammation for a period of time. They don't taste very nice. They may need an nasogastric tube, and you often need high volumes of the milk to meet your calorie needs. Can't eat, and it can be a very long process to reintroduce food. And my concern is, although I have no evidence for this, that if you take all of your foods out for a very long period of time, that does it affect your tolerance to foods that you didn't previously react to. So targeted elimination diet. So why don't we allergy test? Well, Dr. Oliver explained this very, very eruditely, so I will go over this very quickly. Is that actually we can't work out, because the reaction is not the same as an immediate allergy reaction. It's a more delayed reaction. It doesn't work just through IgE. There are new tests being developed, but so far there is nothing that we've worked out for an individual patient that works. Obviously, if we use empiric diets and they don't work, then I have had patients where I've taken out 1 or 2 things more, back that up with a bit of blood allergy testing, things like barley, and that has been effective. So the empiric diets, these were initially developed as a 6-food elimination diet. We all did this. The Americans were actually doing endoscopies every week when they started. It's terribly intense. And so a step-up elimination strategy has been proposed, and also much longer periods of time on an elimination diet in order to to know whether it's working or not. Initially, people were thinking about 1 week, 2 weeks, 4 weeks, and actually there is evidence that you're even getting further effect having been on a diet for 12 weeks. So we tend to go for around 6-8 weeks for a scope after starting, because people want to know whether there's been a significant impact on their lives or not, and whether they can reintroduce the things that they like. So the 6 main foods, which I'm sure many of you are aware of, are milk, wheat, plus or minus gluten. And the gluten debate is very interesting, and it's easier to take out all gluten and then consider re-adding in soya, egg, nuts, fish, and shellfish. And the Spanish in particular add all gluten containing products and other grains. You can see that if you take out one food, this is still very effective. You will get remission in half of patients. But if you start taking out more, you will get remission in a higher percentage of patients at 6 weeks at time. So there have been lots of debate in the literature whether you start with 1 food, then 2, then 4, then 6, or start with 2, 4, and 6. This means you get less overall endoscopies. You eliminate the most common food triggers first, which are milk and wheat in the UK, and up to 75% of responders to a 2-food elimination diet will show 1 food that they respond to. It does decrease your dietary restrictions, and it does make it a little bit easier to stick to the diet, but there is quite a lot of fall off on the way. People have tried 2 foods, there's no way they're going to try 4 and then 6. And I sometimes do a 2 food, then a 6 food to shorten things, but it depends on the interaction between the person and their doctor and their dietitian. A dietitian is essential, and we usually do each elimination diet for at least somewhere between around 8 to 12 weeks. We then do an endoscopy, and then we food reintroduce, and ideally 1 food at a time, and then rescope. And that's where it gets very difficult. If you've got very clear symptoms, they go away, and then you reintroduce something and they give you symptoms. That's much easier than someone who's got subtle symptoms. But again, it's a debate about the timing of these things, and we usually do it together to make a plan that works for family and doctor. There are lots of advantages, because once you know you can't take milk and wheat, then you know what you're doing. You can be more confident in social situations, and you're not on a medicine every morning, so you can get into habits and your life becomes a new norm. And in fact, some families have said to me they're fabulous, they don't want to ever see milk again. None of them take milk in their diet, and they all feel better for it. But quite a lot of teenagers especially find they're missing out on favorite foods. Younger children who eat a very limited diet feel them really struggle, and families struggle to find alternatives they like. It does require patience. It does require you to think outside the box. It requires you to think about different recipes. It's also a lot more expensive. The newer milks seem to be twice the price of doorstep cow's milk. Other foods that you get are not the same, and especially if you're gluten-free, you've got the added burden, and also you've got the burden of endoscopy. So a brief word on combining therapy. So it's usual to stay on omeprazole if it's been even partially effective. Using omeprazole and topical steroids may increase the how effective it is. Sometimes we use topical steroids and dietary therapy if you have a severe disease, at least initially. And more recently, there's been quite an interesting paper published suggesting that trying to start with steroids and diet, then removing the steroids and leaving you on a milk and wheat-free diet didn't really show very much effect, but it does challenge us to think differently about how we use medications and how we use diet in this disorder. When you've been off these foods, long-term avoidance is currently recommended, and most patients will relapse upon reintroduction of the food trigger. I have got at least a handful of patients where they've just been milk-free. We've managed to reintroduce milk, but patients who've been on more than 1 dietary exclusion successfully has been very difficult, and if milk seems to be one that you may get some tolerance for at least a year or two before symptoms return, and further long-term studies are needed on this. So how do I know if the treatment isn't working? This is very interesting. I see a lot of people in clinic who come back and go, oh, we've got no symptoms, everything's great. And then you go through the PEAS questionnaire and then you go through, are you choking? I ask a series of questions which bore my patients every single clinic, every single time. Are you drinking more water with meals? And quite often the answers between the young person and the grown-up are quite different. So the trouble with symptoms coming back is that you may not notice them because they're insidious. They come back very slowly. You adapt your behavior. You just automatically drink a little bit more water with meals, automatically chew things a bit slower, just take a little bit longer. There may be a seasonal pattern, and symptoms themselves actually do seem to become more minimal with time. So to sum all that up, we have good treatments available, and for most patients, we can get things to work most of the time. But the treatments that we have, as in most disorders, side effects are possible. Difficulty sticking to diets, difficulty remembering to take medicines, all of these, especially if you're a well person, you don't often feel systemically unwell when you have eosinophilic esophagitis, and especially teenagers, they're still running around, they've got pots of energy, they can concentrate on their work. Why would they want to take omeprazole or steroids in the morning if they don't have any symptoms? We don't have a good blood test yet to say, oh yes, you need to be more conscious of what you're doing. And the need for repeated scopes and reevaluation is also important and an issue. So there are trials underway to see whether one approach is better than another, looking at new therapies. And I think what's interesting is better ways of evaluating disease activity. So there's the cytosponge, there's the endostring that you can swallow, adults swallow, and you pull back the string and you get a little bit of a lining of the esophagus, and they can use that to see if there's eosinophils in it. In children, there's been a really interesting study in Australia piloting nasal endoscopy awake using 3D movie goggles, and they found that 97% of children did not need any anesthetic, any midazolam, any sedation, and they tolerated the scope and the biopsies awake with 3D movie goggles on. So there's the power of Disney and the power of these things. We are looking to try this in Glasgow. I'm just waiting to see my adult colleagues and see what nasal endoscopy is like. We don't yet do that very much in children. So there are things coming that may make life a little bit simpler. Thank you very much for your time. I'm aware we've used up a lot of your evening.